All right, Angie, now I will hand it over to you.
Hi, good morning, everyone. Thanks for joining us this morning on the webinar, and thank you to Dr. April Fernando and Dr. John Lyons for being willing to come and present today. We really appreciate your time and expertise in going over the Child and Adolescent Needs and Strengths CANS tool, the latent class analysis, and the decision support model that have been created to support us here in California as we move to our new permanent rate system. Next slide. So that's what we'll be covering. We're going to start with an overview of the CANS itself and a history of the utilization of CANS in California. Sarah Rogers, our branch chief for the System of Care branch, will be talking about the history of that utilization in California. Then we're going to overview the latent class analysis and how the latent class analysis is being used in California and how that then fed into our decision support model. And then how the LCA and the decision support model have informed the development of our proposed tiered rate system. Next slide. So this is just a visual of how these things sort of connect to one another. It's all part of person-centered design. We have the CANS assessment and the latent class analysis, which together lead to that decision support model. Next slide. And we'll start with the CANS assessment, and I'm going to turn it over to Dr. Fernando to walk us through. Thank you so much, Dr. Fernando.
Thank you. It's nice to be here. So the youth and families that come to our attention do so because their needs have outstripped their own ability to address them. Youth and families come to us at a point of vulnerability, and how we engage them and provide them care actually matters. The main goal of our engagement, particularly at the start, is to really understand youth and their family story. We do this by listening, being curious, taking in the many perspectives on the youth and their family and their situation, and coming to an agreement with the youth and the family on where they could benefit from help and how we can go about providing them the supports that they need. Gathering the youth and family story matters. If I could have the next slide, please. The CANS is a way that we can capture the youth and family story and identify their needs and strengths to develop a plan that guides their care. This is done through a collaborative, transparent, and a consensus-building care process that actually starts from assessment and goes to planning and then extends to exit from care. The CANS then is foundational in helping us understand what people need and how best to provide supports to them. Next slide, please. When used in the child and family team, the CANS becomes a really powerful way to lift up the voice of the youth and the family and helps the entire team speak a common language that can facilitate the teaming process as well as the coordination of care. And within that CFT, the CANS can do what it really does best: organize, prioritize, and highlight people's strengths and needs, and help to create an environment where identifying supports and tracking change is a collaborative effort. It's about people and not about the CANS. And with that, I'm going to turn it over to Sarah.
We are in the same room, as folks can see. Good morning, everyone. I wanted to just share with the group some of the history of the selection of CANS as our functional assessment tool. In 2017 and prior, under the Continuum of Care Reform Act, the department was required to identify a functional assessment tool to support implementation of CCR. And through that project, we partnered with CWDA and counties in order to evaluate two potential options that were considered. One was something called the TOP Treatment Outcome Protocol tool, and that was considered, as well as the CANS. And we had pilots, both of those tools, with the partnership of counties. And then following that that time in 2017, within that time in 2017, we were also simultaneously implementing the policy for child and family teaming. And so all of those things coincided, which was, really fortuitous in many respects, because we were developing these policies around child and family teaming at the same time that we're implementing the tools that are requiring that teaming process. And so it was an opportunity to really make a decision for the future. We had an actual outcome study with the Harder and Associates that we also partnered and had stakeholder engagement around. And then that report is available upon request. In 2018, following that assessment and study, we did select the CANs, and we chose the IP CANs, and DHCS also aligned with the CANS 50 to support the child welfare, the mental health screening component of our processes within the context of a child and family team. So you can see the historical guidance that was released that related to those decisions, ACL 1684 in 2017 and 1809 in 2018. And then in 2021 is when we released the guidance that required the CANs to be entered into the care system. And you can see that reflected in ACL 21-27. And then through that work, we have now arrived at where we are today in terms of embedding the CANs tool as the underlying infrastructure for our rates proposal. And, as a side note, just noting that we are also engaged very closely with Department of Healthcare Services to continue the alignment of the CANs, both in terms of the tool itself, as well as the processes, timelines, and really ensuring that we are moving toward a more integrated model for between the child welfare system and our mental health system around how the CANs is conducted and even used. I think that's all, and I'm going to now hand it over to John.
Oh,
John, you're muted.
Yeah.
So as Dr. Fernando had said, the CANS is a container for the child and family story, a way to capture it and communicate it. So as we move increasingly towards using it for all sorts of decisions, and particularly when you start using it for financial decisions, there's always going to be concern about the reliability and accuracy of any metrics that you're using for that purpose. So we're quite intentional about reliability with the CANs, and so it really starts with the training, where people have to train to a reliability of 0.70 or higher. The average reliability in California is over 0.78, so it's really pretty robust. And we monitor that reliability training quite carefully. So doesn't happen very often, but every now and then we catch people who are cheating. And so we can identify that with their pattern of uses on the training website and address it with additional training. So, because we really want to create a culture in which learning to talk to each other accurately, as accurately as possible about our kids and families is in fact a core value of that system. So that's why we do the reliability training. That's why we do the recertification, because we want to make sure there's no reliability drift, is what it's called in science, that over time you could develop habits. So that's why you recheck, and people actually embed the CANs in their work. The recertification is easy. People who are still struggling with it as a part of their work, sometimes they have to redo the training. So that's reliability. But in terms of the actual field reliability, and the CANs actually is the highest field reliability of any measure. It's actually one of the few metrics that the field reliability has been established to be higher than the training reliability, because if it matters, then people take it seriously. So consensus is a second foundation of accuracy when it comes to something like the CANs, because as you all know, that one person's perspective on a child and family story is one person's perspective, and there could be differences, right? So, my kid's story of their school was always different than the school story of my kids, right? And so you want to be able to bring people together and reach an agreement, because that's actually a foundation of science that's called triangulation in science, but it's a foundation of getting accurate information where you're pulling it from multiple sources and pulling it together. And then transparency is the piece that goes back to field reliability, that if you use it, it becomes useful and then people take it seriously. So that's why I think the state did a really nice job of getting people to just use the cans first before you start tying it into decisions and financial models, et cetera, because the more different things you use a particular communication strategy for, the more honest and robust it becomes. People trust it because it's just something that you use for everything, right? And so that's the basic concept. There's one child, one story. The cans contain, it holds that. And so you want to make as many decisions as possible informed by that. So those are the three pillars of accuracy in the cans. Go to the next slide. So as Angie mentioned, cans is the person. But if you want to actually, so the origin story of the latent class analysis is we were asked by the state to work with your stakeholders to create a placement decision support. So we did an inventory of all the placements. I think you had like 17 plus different placements, and we created a rather sophisticated model of saying, okay, these kind of kids would kind of move into those kind of placements. But when Dr. Fernando presented that to the statewide partners, people looked at it and said, oh my God, you know, our system is just about placements, right? It should be about kids, right? So how do we begin to rethink that? So that opened the door to a possibility of doing things differently. So person-centered design is very, very common in industry. It's Apple is probably seen as one of the companies that first innovated it, but really understanding who the people you're trying to help or sell to or whatever, what their characteristics, so you can really design your product or system so that it's consistent with the actual needs. So it hasn't been applied much in child welfare. It's one of the first times it's going to be routinely applied in helping systems in the future, because everybody sees in all the other fields in which it's been used that it's a useful way to think about the work. So latent class analysis is a fairly common approach. It's a machine learning approach. It's sort of a precursor of artificial intelligence, but it's not AI, but it's one of the methods in machine learning that you can use to begin to understand it. So it's the design component of this initiative. So if you think about how it works, so anytime you start looking at entire populations, you have to simplify things in important ways, right? So one way you can simplify the cans to make it more robust, and I think it's particularly relevant for financial considerations, the distinction between a 0 and 1 and a 2 or a 3 is notable. So most of you know the cans, so you know that 0 on the needs and no evidence, 3 is dangerous or disabling, but 2 is actionable. So 2s and 3s are actionable. For the strengths, 0s and 1s are a centerpiece or useful. So those are useful strengths, and 2s or 3s are strengths that you need to build or identify and build. So that distinction is even more reliable than the 4-point distinction, because there is more movement, more stable too, because there's movement between 3s and 2s, for instance, and 0s and 1s sometimes. All right. So we took the cans from everybody, and the way latent class works is, so let me kind of describe it a little bit in passing. Maybe have the next slide as a background. So if you think in 2 dimensions, right? So you have depression and suicide, say. So if you've got actual or not, then you basically have 4 dots, right? So you have 4 different locations. You could either be depressed or not. You could be suicidal or not, right? So 4 different locations. You could locate every child in California in child welfare in one of those 4 locations. So let's add a third variable. Let's say sleep. So now you've got actual or not on sleep. So now you've got, what, 8? No, 16 different locations in that space. Well, if you take that out to 63 different items. So if the CANS is designed to be reliable about at the item level, so you can actually analyze the profile. So now you can't picture 63 dimensions, but it's basically an extension of that three-dimensional space where you can identify a child on all their characteristics, whether they're actual or not. There's actually more locations in that space than there are people who have ever walked the face of the earth. There's over a quadrillion. There's only been 109 billion people ever walked the face of the earth. There's over a quadrillion for just using the actual, not actual across 63 dimensions. So anyway, a lot of space. So a lot of uniqueness. You can't say you're not leaving children to be unique. That being said, however, that is paralyzing if you're trying to do policy, right? Because you can't do something that's different for absolutely everybody. You have to identify ways in which people are similar. So actually, if you picture this 63 dimensional space as a cloud, there are locations in that space. Every child is in a location. There are neighborhoods in that space. And so what LCA does, it's a statistical procedure that allows you to identify groupings of kids who are more like each other than they're like other kids. So we apply that separately to little kids and to school-age kids. And that's important because those kinds of children are different, right? Little kids before school are really rather different. They have a different set of needs. They have a different way of organizing their needs in terms of patterns of those needs than school age. Okay, so we did that. And what we discovered is that there was 4 different neighborhoods, if you will, within the 0 to 5, and 7 different neighborhoods within the 6+. There's a large number of ways that you can work to identify how many classes is the right number. We did a variety of different strategies and kept converging back to this. Just so you all know, we've replicated this basic structure now in 2 other child welfare systems. On the East Coast, in the middle, and California. So very different states, same structure of the kids. So the kids are more similar than the systems, perhaps. Anyway, so we're pretty sure that this is a fairly robust way of thinking about how kids are more similar to each other than they are like other people. All right. So let's have the next slide. So you can take this cloud, they're in 63 dimensions or whatever, and you can project it onto 2 dimensions, right? So that's what this is. So it's not a perfect prediction because you can't picture it, but it gives you an opportunity to picture kids. Now, the reason why this is a little fuzzier than the one you'll see for the older kids is there's actually 3 dimensions for little kids that are pretty important, and there's only 2 dimensions, needs and strengths, for the older kids. So we really should put this as a 3-dimensional slide, and you'll see the separation a lot more clearly because there's that 3rd development characteristic. So anyway, what we found for the little kids is 4 distinct groups. There was one group that was the largest group of kids doing well. So by that, we mean that these are kids that are mostly zeros and everything. They don't have needs and they have pretty robust strengths. There's another group of kids that don't really have needs, but they don't have strengths. That's a different kind of challenge, right? Because those kids, you probably want to think about an intentional identification building strengths. You have a 3rd group that their average age was 0, and they had a lot of exposure characteristics of substance exposure prior to birth and prenatal care issues and so forth. And those were characterized as high risk infants. And then there's a 4th class that had just a whole lot of needs, all sorts of stuff. And those are the complex kids. Keep in mind with this kind of 2-dimensional projection, the size of the area is not a representation of how many kids there are. It's how homogeneous that group is. So the doing well is pretty homogeneous. The complex is not homogeneous at all. All right, got the next slide. Here's the same thing with the older kids. You'll notice that a needs versus strengths basically is what this particular 2-dimensional projection ends up being. It's way cleaner because there's not that 3rd dimension that's so powerful that it is with the little kids. So, and you see there's actually these 7 dimensions. So on the bottom, those are kids that actually don't have a lot of needs. That's why they're on the bottom of the, I don't know what that is. It looks sort of like a dissolving Pop-Tart to me. But anyway, so the doing well is, it's actually the biggest group, but it's the smallest space because it's pretty homogeneous. These are kids that are mostly hovering right around 0. There's a moderate level of strengths, and then there's this no strength group, which is actually about 10% of your population of school-age kids that they don't have a lot of needs, but they have no strengths. So that's an important group to think about from a, I mean, we call it prevention, but that's kind of a misleading concept because prevention is sort of an odd concept of let's do stuff to make sure nothing happens. That's not really what goes on. It's not really how you're successful with kids. What you're really trying to do is build resiliency so that they can withstand when things happen. They will just be okay. And that's really about strength building. So the no strength children are at jeopardy of ending up high need children if bad things happen. Then there's these 4 trauma groups. So there's a mild group that's characterized by depression and anxiety, but they don't have they're not really very dangerous. They just need kind of basic trauma-informed care. Then there's these 2 internalizing, externalizing that are kind of more at the mid-range. Externalizing have more strengths, which is interesting, than the internalizing. And then there's the severe trauma group that we call it, which is really that all of the above. It's a lot like the complex group that we have identified in the little kids. So those are the two visualizations of the results of the LCA. Can I have the next slide? So now the LCA locates kids that are related to each other in their distance based on all 63 characteristics. So you could actually create a decision model that said a future child would be in which of those 7 classes. We don't think that's a good idea because it's not really person-centered. It's a design, LCA is a design component, and you can't have AI until you have HI. So in other words, you really shouldn't be doing machine decision support until you have the human intelligence to be able to model that and do it better. So we think that's premature. So you have to use more of a clinically driven way of grouping the kids consistent with the LCA, but understandable from an English language perspective rather than a bunch of numbers and coefficients that you're adding up, and it creates something obtuse that nobody understands what that on earth you're actually doing. So that's what the decision support model is really about. And that's what makes the person-centered design person-centered, because moving forward, you can actually make decisions based on understanding the person. You're using the LCA to inform the decision model, but not to be the decision model. And the next slide. This, I think, is you, April, so I'm going to turn it back over to Dr. Fernando.
Yeah, so the decision support models, as John said, are really to make sure that we are helping people who are making decisions do so with using the person-centered information, in this case specifically from the CANs. And as Dr. Lyons already mentioned, the latent class provides the structure, but the decision support model helps us understand which children and why they are placed in the different classes. If we can have the next slide, please. So what you're going to see here is a map, and this is by no means a political map, but it's the dark blue states identify the states that are using the CANs statewide. So either in one sector, like child welfare, sometimes in 2, like child welfare, and in behavioral health, like in California. The green states represent states where there is some usage of the CANs, either at the organizational or at the county level. If you turn your attention to the stars now, you will see there are yellow stars and stars that are outlined in white. And some states have both. So the yellow stars represent decision support models that are active. Some of them have been active for a very long time, 15 or more years. Some of them are fairly new. And then the stars that are outlined are where we are developing or revising models. And you can see that the stars that have, the states that have both are where we've got models in play, but we're also either creating new ones or revising the models to incorporating new information. So you can see that the models have been in place for some time around the country. You can have the next slide, please. This is just a recap of what John already mentioned, that when we have the structure, understanding how children look in California in the child welfare system, we now need to figure out how can we describe them from their characteristics. And this is where the CANS comes into play and where the decision support model can be helpful. So the decision support model doesn't only describe the children in the different groups or classes, but it also helps us place children newly entering the system into the right class or group. So that, because we, again, as John said, we don't want to rerun the LCA because we already understand the structure in a pretty robust manner. So John is going to walk through the decision support model with you now.
All right, back on the next slide. So here's just an example of how it works. So you start out with kids are doing well. So you start, everybody's doing well unless otherwise specified. And then you start building from there. So to be the low strengths is you don't have any needs, right? So that's 2.1. You basically don't have needs. And no, yeah, maybe one, right? And that you do have some strengths, but not all strengths. That's how that's designed. So in other words, to be in the low strength group, you want to have minimal needs and have moderate strengths. Have the next slide. So the newborn high risk is, you need to be a newborn, right? So, and then you have an exposure, because that was like a 95% in the class, so 100%, right? Because it's a statistical model, not a clinical model. Medical trauma, and then these kinds of characteristics that are common. So 3.4, at least 3 or more ratings of different kind of functional impairment, so that there's a reason to intervene. So you have these characteristics that put the child at risk, and then you have 3.4 that says, and in fact, that risk has manifested itself in this level of need. Because you do have kids who do have that level of risk that don't end up generating that level of need. And then, okay, so for the complex kids is that this is just the definition of complexity. So if you don't qualify for 3 or 4, you fall back to group 1. So that's how the decision support model is designed for the little ones. Can I have the next slide? For the older kids, so same basic concept. You don't have needs, but you do have strengths. That's character. That will be doing well. Second level of if I could have the next slide. You for the second class, this is the moderate risk. You don't have needs, but you do have some strengths, but not all strengths. And then for the low strength, the strength identification platform, the kids are basically knows you just basically don't have strengths, right? You don't have needs, but you don't have strengths. And then next slide. Same basic logic, but now we're into the trauma pathway. So the first level is there needs to be a trauma history. And then there's got to be, there's some implication of that you're beginning to be concerned about a behavioral health presentation of some type. We're pretty broad here because we know that kids express their traumatic experiences in all sorts of different ways. And so you want to be open to be able to capture all those kids and get them the help they need. The fifth is a little bit more comprehensive. So this actually combines the internalizing and externalizing classes into a single class because they have parallel levels of needs, little bit different levels of strengths. So, and then the next line, the last, this is the severe trauma group. You can see they have a lot more going on. They have trauma experiences, but they have, significant level of behavioral health and significant level of risk, et cetera. So you might notice 6.3 versus 6.4. The runaway and intentional misbehavior are risk escalators. They're not risk by themselves, they're risk escalators. They make other risks even riskier. So that's why that's there. All right. So that gives you a sense of what the decision support models look like. So I'll turn it back over to, I think it's Sarah. But maybe Angie.
Hi, we're both here.
Okay, perfect.
Both of us. So here is the kind of pathway and the timeline by which we have been working to establish the decision support model. You can see that in kind of mid 2022, we began conducting the testing in partnership with IPH on the initial version. The latent class, I'm sorry, I'm trying to get to there we go. And that is, we had been working with IPH prior to that in the development of it. And so then we were testing it in July through October. In the November of 2022, we started to have the conversation that John alluded to around wanting to focus not just on the placement type, but really have a way to discern the actual needs of the child and the strengths of the child. And that was really in response to the extensive amount of feedback we received from the community and the work groups around wanting a system that was enabling children to have resources regardless of their placement setting, and to really build a system that enabled children to have that level of support in whatever location or residence that they happen to be in, i.e. with a grandmother, a relative, a family. And so at our request, IPH began to reformulate the decision support model to focus on those needs and strengths and the level of care instead of just the placement type. And so that's the description of exactly what that entailed that you just heard. In January through September of 2023, the department with IPH also began then testing the reformulated DSM with social worker interviews and expert panels and caregiver surveys. And those activities were conducted in partnership with counties and CWTA, and really wanting to be accountable to the perceptions of the validity and the consistency of the decision support with those involved in the case of the child, and whether they felt that it was consistent with their perceptions. And so that was intended to really do that kind of building the consensus with those who are on the ground and their experience in utilizing the decision support model. We also, in May of 2023, began distributing the latent class analysis to counties upon their request, and also worked with some counties in how they could understand and use that decision, the latent class analysis. And that work will be ongoing as soon as we have the green light to continue that. But I think that work is also intended to not only support the understanding of the decision support model, but just all the different ways that a latent class in the CANS data can inform how we're doing capacity building and how we're ensuring that we're truly responding to the identified needs of a child. And then in June of 2024, we are finalizing that last report regarding that analysis of the data collected in that 3-part study. So that is the overall timeline, a high-level timeline of our work with IPH around the decision support model. And I am Now handing it over to you. Dave.
Sarah and I are switching places in my office. So back to our visual, and hopefully this was a helpful explanation of sort of the history of the selection of CANS, what the CANS does, how we used all of that data through a latent class analysis in order to understand sort of groupings of young people into the neighborhoods that Dr. Lyons was describing, and then developed a decision support model that allows us to understand a child's level of needs and level of strengths so that we could appropriately support that level of needs and strengths. And that's exactly how we're using our decision support model within the proposed rate structure. So next slide, you should all be very familiar with this. This is a visual that we've shared many times over the last many months as we've been discussing the proposed rate structure. So what we have done is created the 3 tiers. And what was interesting is in the conversations that we were all having in 2022, there was a lot of folks saying, we have too many levels of care. LOC, 4 levels plus ISFC, and then the highest acuity of kids have to be within STRTPs. It's too much. It doesn't work because you can only meet the highest level of acuity when kids are placed in the STRTP placements. And it's also not working for the kids within LOC 1, 2, 3, 4. That's too many. And then ISFC. And there was a general, like, sort of gut feeling that the appropriate number of tiers is 3, that there are generally kids that are sort of at the basic level where, and that's exactly what the data has found. That's exactly what our latent class analysis has found. And what we find in the creation of the decision of support model is that we've got children that have varying levels of strengths, but they don't have those identified needs, and they can be grouped together within tier 1. And then we have kids that are on that trauma pathway that Dr. Lyons was describing and have that more intensive and intermediate level of needs, which is the youth that we've put within tier 2. And then we've got the 0 to 5-year-olds that are sort of that high risk group of the complex care infants. And then we've got our complex care youth that are ages 6 and older. And that's really the kids that are within tier 3. And what I think is interesting is it was sort of intuitive that folks said we should really have 3 tiers. And the data very much supported that when we went and looked at the data and we broke it down and we did the significant amount of analysis that we did through the latent class analysis and using this decision support model in order to sort of group kids together according to those that have varying levels of strengths, but no needs, those that have intermediate levels of needs, and those that have the highest acuity of needs. That's exactly what we found. And then we've put that within our proposed rate structure and attached different levels of support based on that understanding. So the tier 1 kids do not have the immediate needs funding because they don't have those needs identified, but they do have support for care and supervision that's higher than that's akin to LOC 4, so sort of bumping all families up to that highest level for LOC 4, and all of those young people would receive the strength building dollars because we know all of the kids in tier 1 have a need for maintaining strengths that have been identified and building additional strengths. And then within tier 2, those 2 things continue so that we're continuing to focus on strength building and strength maintenance, and in addition, identifying the supports needed for addressing those needs that have been identified. And then within tier 3, making sure that there's additional support needed in order to address those high level needs that are identified within kids in that system. So next slide. Interposing these things together, you can see sort of what Dr. Lyons described as the young people that are the 0 to 5-year-olds that are in latent class 1 and 2. Those are our young people 0 to 5 that are doing well or that have low strengths but no identified needs. Those are youth that fall within latent classes 1 and 2, and that would fall within tier 1 of our proposed rate structure. Next slide. Continuing on with the 0 to 5-year-olds, those newborn children with high risks are latent class 3, which corresponds with the children that are within tier 2 within our system. And next slide. And then we have the complex needs 0 to 5-year-olds who are the young people that have that highest acuity of needs. And so those are within tier 3 for 0 to 5-year-olds. There's been some conversation about like why break out the 0 to 5-year-olds from the population of kids that are 6 and older, but we really saw from the analysis that was done the need to sort of differentiate between the two groups, particularly at this level of youth that have the highest acuity of needs, sort of recognizing sort of what kinds of supports are we going to need for these 0 to 5-year-olds, and they look fundamentally different than the young people that are falling within tier 3 plus for the 6 and older population. And so as a policy decision, that's why that distinction is made there. Next slide. And then going to our 6 and older population, tier 1 captures those kids that are doing well, that have some strengths, but not all of the identified strengths, as Dr. Lyons described, as well as those kids that have a need for strength building. They don't have identified strengths, but they still don't have any identified immediate needs either. And so all of those young people are also within those first 3 Layton classes that we have grouped into tier 1. Next slide. And then we have our trauma-informed pathway. These are the kids that have the trauma-informed treatment and the comprehensive support needs. And so those are the young people that are grouped together within tier 2. And then we have, next slide, our kids with the highest level of acuity of needs, which are the kids that have the need for the intensive supports and the specialized supports, those kids within Layton classes 6A and 6B. And those are the young people that are grouped within tier 3 plus. And so this is very data informed way of sort of understanding needs and strengths. I did see a question in the chat that was asking, has a decision support model ever been used to determine rates? And we would say what we're using our decision support model to do is to understand needs and strengths. That's what we're doing. And then as a policy decision, we are saying what level of funding for care and supervision, for strength building, and to address those immediate needs that have been identified, can we provide in order to address those varying levels of strengths and varying levels of needs in a way that sort of makes sense from a rates perspective, right? So that you don't have 15 different rate categories, so that you have the ability to sort of group young people together, but that it's coherent and that it's really understanding and based on a real understanding of the young people that have strengths at varying levels and intensive needs and the highest acuity of needs. And so that's how we've used this decision support model in order to sort of create different levels of support for kids based on those varying levels of needs and strengths. Next slide. Sarah, anything you would add?
No, I think it's great.
These are resources available to you. I think we've mentioned a couple times in this presentation that there's also a report that will be published on the decision support model that we're using in the Layton class analysis. And I think that's coming sometime in June. So we're working on that, which is another question I see in the chat. And then I think we have time to open it up for a few questions. And Emily, I wasn't monitoring the chat much, so I'm not sure if there were additional questions in the chat.
Yeah, there are a few. Let me find a couple. I do see one that says, will you share this presentation? So this is being recorded. We'll get that posted to the DSS foster care rate reform website. Thanks, Daniel, for reinserting that into the chat. And we can also share these slides out afterward with folks that attended. Okay. And Marla asked, how often will the LCA be updated and how will evolution of the LCA over time impact the rate schedule?
Dr. Lyons or Dr. Fernando, do you want to answer that one for how often you're sort of updating Layton class analysis?
Yeah, it sort of depends on what you mean by updating it. I think how all these things work is you want to continue to confirm that the structure of how we're understanding how kids are similar to each other or different. You need to kind of make sure that's not drifting in some important ways. For instance, what's oftentimes the case is as your threshold for taking kids into the system changes, the population of kids that you're serving in the system changes. And so you do have to be attuned to that kind of variation to make sure it needs to keep it current. Whether that's updating the LCA or not, I'm not sure if that's the language I would take. I would just confirming that the structure is still a valid way of understanding the kids. So I think the other thing you always are doing is monitoring the decision support model to see whether or not, there's anybody that's it's not performing appropriately for, and that never ends, right? Because you always want to be keeping your eyes open on that, and that's just an ongoing quality assurance thing. That'll be a standard part of how this stuff works.
And the only thing I would add, I mean, it's somewhat related, is just how important fidelity to CAN's practice is, with respect to the overall validity of this process. And so we really, are acknowledging how essential it is for us to have a strong investment in that fidelity to the beginning of John's presentation around what is CAN supposed to kind of be and how it's supposed to be conducted. And that's a important component that we would be tracking and monitoring and engaging around.
Thank you. All right. Marla asked, how will the decision support model be applied to a child? Will it be built into CARES?
Oh. Yeah, ultimately, this is going to be built into CARES, and so the CANS data will be entered, and then that will be applied. The decision support model will be applied through the CARES system.
Mm-hmm.
I'm seeing a question. Are all counties using the same standardized version of the CANs? Are there any variances?
We are aware that there are counties that may have added components, and there is, and I think April and John, you're probably even more familiar with exactly what that variation may look like county to county. What we are doing is working with GHCS closely to align, as I mentioned before, as far as the required components. But there are some counties that may have additional pieces that, additional components they've added. And April, it looked like you were maybe going to speak to that.
Yeah, you're correct, Sarah. There are other counties have other versions of the tool. They're probably named after their county. We made sure that when we were working with those counties to develop, to customize those versions, that all the items in the IP CANs were there, and that all the items in the core 50 that DHCS uses were there as well. So they have more, not less.
So I think that actually speaks to a issue that sometimes leads to misunderstanding, because if you are trained like I was as a psychometrician, then whether you add or subtract items changes the tool in some way. That's true in psychometric theory, because all of your measures are evaluated based on the inter-item correlation matrix. So there's just a paper recently published saying, well, depression is more correlated with suicide than it is with conduct, so therefore the CANS is not valid. So the CANS does not base its decisions about what items to include based on the inter-item correlation matrix. It actually bases it on the meaning. So the CANS is more like an APGAR. So in other words, each of the individual items stand alone. And so so long as you have those items in any version, it's the same item and it functions as the same item. So you have the 50 in every county. You might have the 50 plus in some counties, but you don't think of it, oh wait, it's a different measure. That's just thinking about it from the wrong frame. You're thinking about it from a traditional measurement frame, of which it's not. It's like saying, well, I only use these words and I want to also add these words to my sentences, and therefore it changes those words. No, not really. So words are words. And they mean the same thing, even if you add adjectives, right? So that's it. I mean, so it's just a different way of thinking about stuff. I didn't, if you want to read about communometrics and what that all means, there's a number of different resources that are available. There's some stuff on the YouTube channel that you can look at, but it's just a different way of thinking about things.
Yeah. All right. Which version of the CANs will determine the rates? The first child welfare CANs, the first behavioral health CANs, and will subsequent CANs change the rates?
So, yeah, go ahead. Do you want to take it?
Yeah, it's the first CANs will determine their tier upon entry into the system, and that has to happen within the first 60 days that a child is in care. So pending the completion of the CANs, the proposed rate structure proposes that youth would start at a level of funding equivalent to the care and supervision component of tier 2. And then once the CANs is complete, they would go into the tier identified by the CANs, which would happen within the first 60 days. And then there'll be guidance that's being created about how often the CANs has to be redone. Right now it's every 6 months, and when it could be done more frequently within that 6-month period, and then how that would inform, like if the CAN score that's done anew, it says the child has moved up or down a tier, what is the process by which we would move the child up and down into the corresponding tier? What we've said is we want to titrate down slowly for kids that are in family placements because we don't want to destabilize those placements, and you'd want to titrate up quickly in order to make sure that kids have the appropriate support that they need, again, in order to stabilize and support those placements.
And the only thing I do want to make clear is that for those counties in which the behavioral health system or partner is the primary entity that is doing the CANs, that we are aware of that. That is not intended to be requiring anyone to do another CANs or anything of that nature. And so that is part of the purpose of the very clear alignment with healthcare services to ensure that all of our systems are getting the same guidance and have the same periodicity, and that alignment is present.
Thank you. All right, we only have a few minutes left, so I think that this will be our last question. It says the original CANs analysis was of 60,662 CANs up to January of 2023. This does not include probation, nor did it include CANs done by behavioral health and not recorded in CARES CANs. Are you going to rerun it?
We're going to pass that to you, Dr. Lyons, please.
Okay, sorry, I was looking at another thing in the chat. Can you repeat that? I apologize, Emily, sorry.
Oh, no, no need to apologize. Apologies, I scrolled down. Here we go. The original CANs analysis was of 60,662 CANs up to January of 2023. This did not include probation, nor did it include CANs done by behavioral health, but not recorded in daycare's CANs. Are you going to rerun it?
Yeah, the more data, the better. What you don't want to do, though, is include kids to just have a behavioral health CANs that are not in the child welfare system. So that it's really important with LCA that you pay attention to the denominator, because you're really describing the population. So if you start combining populations, it creates a different sort of set of considerations, and the implications are going to be different. So the plan is to update with new data. I think there'll be there's been far greater participation of counties in the placing data into CARES over time, and so I think the data will be even more robust. But yeah, you just need to go and replicate it with new data. That is planned for this summer, I believe, is the agenda. So, or late spring. I don't know. Is this summer or spring? I don't know what it is. I'm kind of thinking it's summer, but it's hotter than heck here. So. Does that address your question? Is that on point to what that question is?
I mean, the only thing that we were thinking, we have talked about, the anticipated impact of that. And, I think you and Olga and others have indicated that in your experience, adding these other populations may have some refinement to the LCA, but not in such a manner that it's likely to substantially change. And so it might be helpful to speak to, in your broad experience, what you would anticipate the kinds of refinements that you'd see.
I think the big refinement, I don't think it's going to have much of an impact on the strength pathway. I think more data will provide some greater clarity within the severe trauma group. Because if you look at the visualization of that, that's actually the biggest region. That's the most space covered, which means there's a lot of variability within that by child. They're all very, very complex. And so it makes sense that they're your top tier. But probably within that, there's kind of different, not necessarily different intensity of need, but maybe different practice approach that is important to understand. So I think the clarifications will really be in the practice approach kind of space rather than the overall intensity, because I think the overall intensity is pretty robust. And since we've seen the same thing in 2 other big states with huge data sets, I'm pretty confident that it's not going to be something different in terms of the basic structure. But I do think that severe class, which is very diverse but very severe, probably can be understood from a practice perspective with a little bit more nuance.
And that speaks a little bit to like the design of our rates proposal generally, that like it's not based, we didn't design the decisions, we did not ask for a decision support model that leads to a placement, because we think the placement itself is not the thing that can have the level of variability in order to really individualize and meet a child's needs. And so we can correctly identify the kids with the most complex needs based on the tools that we're utilizing here and the data. And then at that level, I think as Dr. Lyons is saying, within the most complexity, there could be a lot of variability in how you address those needs. So having a decision support model that helps us understand that variability, and a rate system that's designed to meet variability. So having immediate needs funding that's not tied to a placement, but tied to a child, allows us to make sure that we're individualizing how those dollars are used to meet that child's individual needs. And so by design, we have tried to create a system that is very individualized, so that those strength building dollars are attached to the child and the immediate needs dollars are attached to the child, to allow for that individualization that we know is necessary. Because what this model tells us is the neighborhoods of the kids. It tells us sort of generally kids that have different levels of strengths, where they have those intermediate and moderate levels of needs, and where they have high acuity of needs. And the CANS data itself for that particular child can give a lot of insight about what that individual child needs. And we want to do both. We want a rate system that sort of attaches a level of funding and support to the child that allows us to do those sort of broad groupings. And we want that individualization. So we didn't want something that shoved kids into different placements. We wanted something that allowed us to customize a level of support to that child based on sort of broad dollar amounts, right? We can't provide an individualized level of funding for each individual child. That's not how foster care rates work. But we can provide flexibility in terms of how those dollars are used in order to really meet that child's needs. And that is really the vision of the model.
Well, thank you so much. We are a little bit over, so I do want to acknowledge that, but thank you so much, Dr. Lyons and Dr. Fernando and Angie and Sarah, for a very helpful overview. As we noted earlier, this is being recorded, so we will get this posted to the DSS foster care rate reform website probably in the next week or so. All right, thank you so much. I hope everyone has a great rest of your day.
Thank you, everybody.